I'm Ashish Patel. I'm a consultant vascular and endovascular surgeon at Guy's and St Thomas's NHS Foundation Trust. Aortoiliac disease is a very common presentation in our patient cohorts. There are two main options here. One is to use covered stents and the other is to use bare metal stents. The data, however, are quite equivocal. Original data suggested that we should be using covered stents to treat these lesions. However, more recent data, the Discover trial, for example, suggested that perhaps both stent types are quite equivocal, but perhaps the more complex lesions, the task C and D lesions, might be better served by covered stenting. So in my practice, my approach is to use covered stents for the aortoiliac area, and then perhaps for the distal part of the iliac segment, the external iliac, to use uncovered bare metal self-expanding stents. This is a very effective way of treating these patients. The options are to use kissing stents or to create a CIRAB system. However, there are some anatomical limitations. Some patients have very small aortas, or they have a mismatch between the aorta and the common iliac arteries, and therefore you cannot place two kissing stents effectively that essentially fit inside a very small aorta. So in patients with these tricky anatomical variations, often we don't want to place stents into the aorta, especially when the aorta is small and the iliacs may be slightly bigger than expected. Fortunately, we now have the new Shockwave L6 device. This now modifies the iliac vessels, makes them more compliant, and allows us to then place these covered stents much more accurately. It also means that we don't have to extend these stents into the aorta, so this may maintain future options for up and over access in this patient cohort who often need reinterventions. So I have a case which illustrates just this. A 75-year-old lady came to my clinic with rest pain of her right foot and very short distance claudication of her left leg. She was an ex-smoker, but relatively independent, and was really struggling at home and not sleeping at night. So as you can see from the CT scan, she has a mismatch between her aorta and her iliac vessels. The aorta actually tapers down to 10 millimeters from around 13 to 14 millimeters, and her iliac arteries only measure 4 to 5 millimeters at the common iliac origins. This is not a good configuration for kissing iliac stents or a CIRAB. In this case, I also used IVUS in order to accurately measure the size of her aorta, both the proximal and the distal aorta, as well as the common iliac arteries, in case after treatment we ended up having to either perform a CIRAB or high kissing stents, and I wanted to make sure the sizing was accurate. So as you can see from the IVUS and the angiogram, she had very focal stenoses of her common iliac arteries. Distal to this, her vessels were actually a bit bigger, and I felt that there was an opportunity here to really target the Shockwave L6 device at those common iliac arteries in order to allow them to become more compliant and fully expand in order to place a better sized stent. So the current L6 Shockwave configuration allows you to then focus the emission, focus the shockwaves at that point in the vessel. So just distal to both of her common iliac lesions, the vessel was measuring around 6 to 7 millimeters. It's very important to oversize the L6 Shockwave device in order to ensure that there's good apposition to the wall so that the energy is emitted efficiently. So I used a 8 millimeter L6 Shockwave device for the iliac artery and supported the contralateral side with a 6 millimeter plain balloon. I then switched over the devices in order to treat the contralateral side while supporting the ipsilateral side with that same balloon. So the benefit of the new Shockwave L6 device is that it has an optimized emitter configuration so that the energy is emitted equally across the whole catheter. This allows you to really focus the energy across calcified lesions, and after delivering your shocks to a certain segment, you can then bring the whole catheter down without having to overlap too much. This patient also had quite severely calcified external iliac disease, so I was able to use the device to treat that segment as well. So you can see from the angiogram that after the delivery of the shockwaves, the iliac artery has now actually naturally expanded because it's more compliant to its diameter of 7 millimeters. And bearing in mind, this is without angioplasty and only delivery of 4 atmospheres of pressure. So now we came to the stenting part of the procedure, and as you can see here, I had placed two 8mm VBX covered stents. And what was really interesting here was that, as you saw from the original CT scan, the vessel only measured 5mm, but the Shockwave L6 device has allowed me to place much larger stents here, as the vessel is much more compliant and has expanded to a much larger size. And what was very beneficial in this case is that I could place these stents much more accurately in the common iliac arteries and not have to protrude them into her small aorta. So as you saw on the original CT scan, she also had quite severe external iliac artery disease. So it's important to finesse the procedure at the end. So I'll place two bare metal self-expanding silver stents here, and these areas have already been treated with the L6 Shockwave device as well, and these stents have expanded very nicely. So although this lady had very small iliac vessels, the new Shockwave L6 device goes up to 12mm, and I believe in the future it will allow us to treat patients who have larger vessels to increase the compliance of heavily calcified lesions. So the final angiogram showed excellent flow through the aortoiliac segment, and she was discharged home safely. I saw her 6 weeks after her procedure, and she's delighted with the outcome. She's now walking without any problems on the left side, and her rest pain has fully resolved, and she's now sleeping at night. This patient cohort has very severe systemic atherosclerosis, and often they will present with disease progression. So it's very important to maintain the aortic bifurcation for future up and over options. So although covered stents or bare metal stenting is currently thought of as the gold standard treatment, I think the Shockwave L6 device may be considered now as the new first-line treatment to prepare these lesions prior to considering stenting. This may allow for more accurate placement of stents in this complex patient group, and maybe in the future, with better evidence, it may even forego the use of stents at all.